It's 12:03, Mike. If you want to start, you can always
Sure. Yeah.
tag on.
Thanks to everybody who's joining us. Ryan is at Johnny's lecture right now, but he sends his regards to everybody, along with George, Rachel, and Sharon. And I are really grateful that you guys are joining. We want to make sure these are helpful to you guys. There's a couple slides that we'll go through at the beginning just to orient everybody, and to put it out. And this will be recorded, as Rachel said, and posted to the YouTube page in case there's questions about it. We'll reference some of the documents that are already available and that should go up on the member resources page shortly. And then we'll try to answer any questions people have and have this be both productive and hopefully useful if you have questions, and also maybe you'll hear questions that spark your ideas, and make sure that you anticipate questions you might have later on in the process. Like as I said, there'll be some announcements. We'll go through the schedule, which I think Rachel went through at the Tuesday meeting. There'll be some onboarding updates, data entry updates, and then we'll pause and just sort of answer any questions that you guys have. Reminders and announcements. If there are changes in your team, that happens as a natural part of the summer, and also as teams develop and in the indefinite future, please just get in touch with Rachel, so we can make sure that the RedCap access is maintained. A reminder to all of us to access RedCap every 90 days, and to attend to any training updates that Garrett sends out. I know that I owe him a training update that I'll have to do today to make sure that I maintain access. As you're going through the process, and we can talk about the process if you have questions about it, but we want for your first data entry test for there to be a data champion to enter it, and then the PI or the site PI or site lead to review that as if they were entering it on paper, to both serve as a check to make sure that we all know where the data lives, that both the site PI and data champion are comfortable with the structure of the data, and as an opportunity for you guys to establish a line of communication so that you can answer questions back and forth about both the content and the structure of the stuff that's going on. The member resources page, I hope will be a useful way for us to transmit information, and we'll update the frequently asked questions document as time goes on, both to reflect things that you guys figure out as you're doing the data entry, and so that we're answering the questions the same way as we move forward in time. There are a couple of video tutorials currently on the PVS website as well, and through YouTube, including lectures by Ryan about stuff, and some attached lectures or attached articles. We're hoping that we'll have a surgical one, because that is an area that certainly George and I are not practical clinical experts about, but we're working on that, and that should hopefully come up in the next couple of months. This is a complicated slide, and so I'm not going to try to read this out loud. Suffice to say that on different days of the week, and including times during the day, during the afternoon for people who are on either the East or the West Coast, and then one evening a month, we'll try to make sure that we're available. We're trying to do this intensively early in the process so that there is the opportunity for people to not get bogged down in a question that derails their data entry, and so that we can troubleshoot anything so that we're all entering data in the correct way as we move forward. Yes, so if there are issues with the RedCap onboarding process, you feel like you're stalled and can't access RedCap, and there are a couple steps in the process. If you feel like that's happened to you, again, reach out to Rachel. There should be both a level 1 access and a level 2 access, and then finally, and then a dual authentication step. Once you have all those things, you should be able to access the PVS RedCap. If that is a problem still, let us know. This is a summary of data entry so far. Obviously, we had a head start, and Judah has been working really hard. And I've been trying to keep up with him and answer questions about our patients. George has gotten Vanderbilt off to a good start along with their team. And then Cincinnati, UPMC, and Columbia have gotten started. Again, I hope that for Cincinnati and Columbia, as they've gotten started, that they're going to work to get their paper tests in so that we're making sure that we're starting off on the right foot. I know from some other sites that they're either in the process or have access, but haven't started entering data. But I would encourage people to get started just so that you can get some momentum, even if it's just to establish how you're going to identify cohorts of patients and start to enter the data. All right, I'm going to take down the slides now, and then we'll answer any questions people have as they come up, or we can talk about processes if there are questions about that. So can I take a straw poll? I'm looking around at the people who are logged in. I see people who I recognize. I know Abby is at and Jody where they are. So St. Louis and UPMC. I know that Judah works with us here at CHOP. Um, or where are everyone else from, and where are you guys at in terms of the process? People who weren't on that last slide. Everybody rushed to the front at once. I'm going to start calling on people just so we can start this. Megan, am I pronouncing your name right? Megan Colmer.
Yeah, go ahead. Yeah.
And so I can tell that you're from Cincinnati now that your picture is big enough for my old eyes to see.
Yeah.
Where are you guys at in terms of the process right now?
So we have to use Analytics Manager platform to like pull data from Apollo LX, that's CT surgery and cath data. And so we have created like the query. And so it brought back a list of patients, but then a lot of them, we thought we had like 40 or 60, the doctors thought we had 40 or 60 patients. And then I was like looking at it, and I think a lot of them are kind of excluded from just my nursing look at it.
Mhm.
And so it is right now, it's at Shabana's desk to like weed through the patients because I have
Perfect.
these comments of like, hey, I think this is excluded. And so that's where we're at right now.
That's great. I think that that process is going to be true at every place, and we certainly did that. I think if as a hint that might be helpful for in your process, that Judah, you can tell me if this is good or not. One of the things that is inconsistently recorded in a lot of PVS surgical and catheter notes is what the veins are. And so if Shabana, while she's looking at each of these patients, can determine which of the veins are truly affected or unaffected, that
Mhm.
can give you a sort of a step up. It's another column we added to our screening list. And it may help you guys clinically just to have a list of your PVS patients that you can then add. We share ours so that, because Ryan and I are both engaged, and Judah, so that we can have something that's like a living document that we work with. From both a site lead and data champion perspective, are you guys okay with having gotten access to the REDCap?
Yeah, it was fine. I think Amy
Okay.
was fine too, right? Like
That's great. I don't, I just want to make sure that if there's a problem with it, we can
Rachel
troubleshoot
helped,
it
yeah.
as okay, perfect. Thank you.
Yeah, so
Um,
for our site, both Megan and I have access. Sean gained access. I told Shivana not to get access until
mhm.
she absolutely has to. And she was happy to hear that. So
Yeah, as long as the one thing that she'll need, either Sean or her should be the person who reviews your first true entry. And that you could like, sit next to each other if you wanted to, or you could, you could have them get access. But either way would work.
yeah, we've done that one with her. She or screen share in her office. She has an extra
Yeah.
setup, so
That
it's
might
a lot
even be like a
easier.
really efficient way to do it so that you're actually like seeing the same thing at the same time. That'd be great.
Yep.
Um, Abby from St. Louis, how things going there?
So we actually, oh, sorry if you can hear me. We just met as a team on Tuesday, and I think we have a student who's going to help us. Dom is fully onboarded, and he and another Manish, they're working on pulling a list for us. And then I think Rachel Way, our student who's going to help kind of manage the data. Um, I think we need to reach back out to Garrett. I don't, her email has been a little wonky lately because she was a student and now she's post grad. So we just need to get that squared away so she can get her training completed.
Okay, great. Yeah, again, I think as you guys are screening, at least in our experience, STS and impact are specific or
Yeah.
sensitive, but not necessarily very specific. So you'll get a lot of true but not eligible patients, and hopefully not miss
Okay.
anybody. But I do think that having a conversation and a process where the site lead looks through that will be really helpful because many times at most centers, one or two docs are doing a lot of the PVS cases, and they'll be aware if there's something missing from the roster, if you will.
Got it. Okay.
I'm just going to keep working down the list. Jody, I know you guys at Pittsburgh have done a really good job and have had a lot of really good questions that Sarah's forwarded to us. Anything from your guys' perspective?
No, honestly, Nick has been doing the entry. I sat with him and Sarah and we worked on it together. We've just been using the approach to pick what we think are going to be the most difficult cases while we have her help. And then, sorry, I have company. And then, she is going over with it with us step by step. And, it's been helpful to do it that way. So,
Yeah, I hope that over time it'll get a little bit easier, and as you guys get familiar with the sort of structure of everything, and then
well,
you know,
that's
the
how I found
content
the
is going to get
capital
better. Yeah.
dependent side to be. So I think it'll be the same way too.
Great.
But I do feel like the videos on YouTube and all the steps have been very helpful. Like the things that we struggled with on the capital dependent side, everybody took to heart and really tried to make it easier to start this out.
Great. I'm glad to hear that. I know you guys had trouble at least once with a bug in branching logic where a field that was supposed to appear didn't. I just want to use it as an opportunity to call it out. Judah encountered that here too. And by just going back a step and removing the initial entry of what the vein was, at least we were able to see it again. If that happens again, let us know. It shouldn't happen. REDCap should function perfectly every time, but it's happened at least once or twice, and I don't think it's a fundamental flaw with the programming of the registry, but we can't have a sense of how big a problem it is. But just, yeah, don't assume that it's if you see that where you enter a field like an other field or something that you know has a contingent or a resultant field, if it doesn't pop up, every once in a while that seems to happen. We don't have a sense of the scope of why that's happening. I think it's a REDCap issue, but if we know better, that'll be helpful. I just want to call it out now so that if it happens to anybody else on the call, we know about it.
And
Okay.
I think the best way to get a hold of us would be that email, that
Yeah.
PVS at CCRC Research. That's by far and away the best way to contact.
Yeah, that goes to Rachel, Ryan, George, and myself. And you know, each of us are individually busy, but you know, all of us also like spend our whole days with like our email up. And so I think the response time has been only a couple hours for most of us getting something back and being able to work through stuff really quickly that way. I hope that works as we move forward. Judah, do you have anything to talk about in regards to what we've been doing here? I know you've entered a lot of data and we've been answering questions and sort of clarifying stuff.
No, yeah, it's just basically, with anything, I just ask multiple questions. There's always going to be confusion, at least from my end, with in terms of the veins and clarification. So I think it's important to communicate because, as Mike knows and Ryan knows, as going back and forth, there's been some, all of a sudden it's like you're doing like left upper, left lower. Next, here comes like a left common pulmonary vein. So you need to get that, you know, clarified, like, what the anatomy is, or if they're calling it out correctly. That's my only thing that I could, suggest to, everybody.
Yeah, I would
Other than
reinforce
that,
that when we're
like you
talking.
said, the calling out certain things, like, like I believe like the anomalous left upper pulmonary vein occasionally pops up or doesn't. So that was the only thing that I've kind of found.
Yeah, I want to just emphasize that again because I don't think that I realized in retrospect, looking at a cath report, sort of just taken in isolation, how sometimes that is hard to understand what veins are affected and what the total anatomy, what the picture of the veins is. And so both at our site, we've added a column in the screening list where the site lead enters what veins there are and what veins are stenotic, to our knowledge, so that is like absolutely objectively clear. And then for both our new patients who are undergoing initial evaluation and in patients who are undergoing serial catheterizations, we've added some templated text that gets added to the end of the cath report that says, for left upper pulmonary vein, it was intervened on with these things. The left lower was intervened on with these things. It has upstream stenosis or not. the right upper was not intervened on, the right lower was not intervened on. And so hopefully, that's a very small added marginal effort for the attending of record. And it's like it saves, I don't know, probably saves 5 or 10 minutes at least, maybe a little longer in a complicated case for the data champion. And so we can't go back and we have a whole like 70 patient prevalent population of eligible patients. We can't fix that for all of them and for every single cath they've had, but at least moving forward, that'll be easier. And then I think, and I hope that as some of our older patients are coming forward to their next cath, we can clarify some of those issues for what their historical issues are so that Judah has an easier time moving forward. Um,
And then the only other thing too, that I know that I brought up to you, Mike, and it was discussed at some point, maybe at the conference, um, is that like specific veins, like if they weren't, like if they had a specific cath and they didn't look at the right upper pulmonary vein because it's atretic or something along those lines, and there's no data in that, but
yeah, I want to be clear about that. I think if they know that it's, they may not have what we document very clearly in cath reports is where we intervene, right? Where a wire is placed, where a balloon is placed. Oftentimes we take angiograms that clear or make us aware that the normal veins are normal. And so they may not call that out. And so I think that for us, at least, our templated things will say that. But what we really care about in those subsequent um, catheterizations is whether they were intervened on or not. That's how we're tracking that. And so it's not, we're not measuring severity of disease. You can assume that there's no upstream stenosis in a vein that's not intervened on. But you can, if it doesn't say that they intervened, you can write that there was no intervention there. And that's how we're tracking that. And at the annual report, you're using a combination of imaging data and the caths. And if there's never been intervention, there's no sign of disease, then it's still there on the echo, then you're good. Does that make sense? Because remember, we're not measuring, we have a very sort of broad definition of severity of pulmonary vein stenosis by angiography or by imaging, which is only really entered at the initial evaluation, where it's mild to moderate, severe, and atretic. And then we care about atresia later, but you're not going at every cath and measuring how severe the pulmonary vein stenosis is, either by pressure or by angiography. And that, again, is intentional, not because it's not important, but because it would be really kind of a pain and it would require a lot of, you almost would need a core lab or have every catheterizer measure every time, which is certainly not everyone's practice. That was a choice to try to make this easier to enter data for you guys.
Yeah, and I think one of the things that we'll also do too on all of the monthly calls and the meetings, thing of that nature, is just continue to try to emphasize trying to keep some of the language in the reports more
Absolutely.
for all the participating centers, or continue to try to encourage it.
Yeah, and we've already had some discussions in our group, like the 3 or 4 of us who do most of these cases. There are some things that we say differently, and it does require a little bit of being adaptable, and that's not a trait that all of us are great at, but we're going to work on it too. I'm going down the list. Am I pronouncing your name right? Mina, where are you from, and what's going on with you guys?
Hi, yeah, it's Mina, that's right. I'm from UCSF and we are just in the process of getting Red Cap access right now and haven't done much else beyond that.
Okay, yeah, keep in touch with us about it. I think it is a process that if you're getting at least the emails and starting that process, it can take a couple days, and there are some places where you can get kind of bogged down, but I think it is a process that works but it does require like a little bit of attention. If there are things that you feel like you're getting hung up on, please let us know.
Okay, will do. Thank you.
All right. And then I think Anna, you're at Columbia, I think based on the caption.
One of the residents actually at Columbia working with Usha Krishnan.
Great.
I have we haven't started inputting data because we have a few questions about like specific lines, and I apologize if you guys have already gone over these. But we have a few questions about like one specific was in the like baseline clinical data section, the like respiratory support line. It basically says there's an area for like previous respiratory support and it's options for like non-conventional ventilator or oscillator, and that's it. And a lot of our kids are on like CPAP, BiPAP, things like that. And we're wondering like what people have been doing. Because it's not like
Yeah, again,
no
I think that
respiratory.
in the current support, there is like a line for, the sort of non-invasive positive pressure support, nasal cannula, between nasal cannula and intubation, and then that. But chronic support was, sort of I guess it's in the model that, a lot of our centers don't use bubble CPAP for BPD. And so if they haven't been intubated or on positive pressure ventilation or an oscillator, you can say the next category down.
Next Saturday. Yeah, because there's
Yeah.
basically like for previous respiratory support, it's just
Yeah, and again, I
non-ventilator.
want to clarify for that it's previous respiratory support, not for a diagnostic study or a cath, right? So like if they get intubated for sedation or purposes, then don't include that. But it's whether they were chronically required that a respiratory failure of some kind.
Got it. And to clarify, previous refers to before the first
That's right.
diagnosis. Okay.
Yeah,
Okay.
before we have to create this sort of artificial construct of when we started treating their pulmonary vein stenosis. And that is a little clearer if they have a catheterization. It's a little bit more vague if they have a surgery, right? Because the diagnostic study is some combination of an imaging study, whether it's an echo or a CT. But I guess it's from the treatment back, but then we would include that they had, this idea is a little bit, the timer, which is really important as we move forward, is from the treatment, and the respiratory therapy is from before that. That's right. So not from like today, some of our
Got it.
patients, are
Previous.
3 or 4 years
Yeah.
out now. That's right. That's a very good question. Thank you for asking that.
No problem. I have a couple others. I don't know if this is the right like time and
This is
place
exactly the
for
time.
like.
This is why
Okay.
we're here right now.
Okay, sounds good. And then the other questions were basically in the like hospitalization section. I know we're like trying to balance not getting like bogged down with burdening people with too much details, but there wasn't a section for reason for hospitalization, but there is a section for ICU number of
Yeah.
days. So it seems like the ICU stay days is used to help determine like how severe the hospitalization
Yeah,
is. But
the idea for hospitalizations is just to try to capture how long that they're not at home, and as a resource utilization issue. In terms of like, capturing the burden of respiratory disease or other things, that really was very hard. And right. And then for many of these patients, the reason that they're being admitted is unclear, right? They come in with respiratory distress and it's not clear whether it's an infection, congenital heart disease issues with heart failure, or pulmonary vein stenosis that's either recurrent, recalcitrant, or gotten worse suddenly. And so to, again, avoid, you know, having this session every week, adjudicating every single hospital admission for these patients. Uh, and so that's the question, and that's the reason. And so,
okay.
and then simultaneously not tracking every respiratory infection for every agent, that's an important thing because many of these patients are treated with immunomodulatory agents, and we are worried that they have opportunistic infections. But we just there were like hard discussions about exactly where to draw the line of how much data we collected, for
Yeah,
sure.
yeah, that makes sense. It makes sense for it to be like a burden of not being at home. Because I was gonna say like a lot of our kids who are already on respiratory support, when they go in for just like a 1 day cath, have to go to the ICU after.
Totally.
And they're
We do the
not
same
sick.
thing.
Yeah,
Yeah.
exactly. But it does like it's like a day away from home. So I guess seeing it from that perspective is helpful. Um, and then the last thing was just the wording around the timeline for the medication section.
Yeah.
If we could just like maybe go through an example of like what just because it's there we were all like a little confused by the like starting with the first year in the registry
Yeah.
counting.
So yeah, so let's imagine a patient who got their heart catheterization today. My colleague Jess is taking a patient today, so they're a new patient. They're going to get PVS. Starting
Mhm,
today is when the first day they'd be eligible for counting the medications.
mhm,
June 12th of 2027 would be the first time, or sometime with some wobble room, maybe after that, you could look back. And you'd look back and you're trying to identify what medications they were on for greater than that duration of time during that year. And, the the domain, the epidemiologic concept we're trying to capture is whether they were treated with a medication for a decent period of time. And the reason why they're focused on pulmonary vasodilators, antiproliferative agents, biologics, and anticoagulants is those are medications that they're receiving for a long time. And we can't say we don't do doses. We can't talk about adherence. We can only talk about whether they were prescribed that medication. So if they were, if they chose not to start sirolimus today because the family was not interested, but they started it 3 months from now and they were on it they were prescribed it for 6 months, but they stopped every once in a while because they had to get a G-tube surgery and myringostomy tubes and a circumcision, which does happen, and we have to stop medications for that reason. You would check off sirolimus.
Mhm.
If they received Lasix for a week or after every cath for 1 day because they got excessive fluid overload during anesthesia, so they received it for a total of 7 days during the year, wouldn't count that. But that's not the medication we're counting. But same thing with heparin or things like that. But if
And
they were
then,
treated with Plavix and aspirin for 3 months because they got stented 9 months from now, then that would also count.
yeah. And then in the sections, that makes sense. In the sections where it says what year does a set of medications cover, is that like year one or is that like
You're
2027?
counting up from 1, 2, 3, 4, 5, 6. And the reason why that has to be there is because these repeating measures in REDCap, they show up as like a nested series of sheets. And so if you don't label them, you could like maybe try to figure it out, but it can be very confusing. And so that the fact that there are dates and numbers allows us to double check that. And you
Okay.
should
And then,
start with 1 and then you count up.
Yeah. Just like Maya said, go with 1. Don't say 2025.
That's right.
okay. And
Sorry.
that's the
Yeah.
same with like, it aligns with the annual form. Like the
That's right.
annual form is like
That's right.
1 year, 2027, June 12th. And we're looking back in the previous year.
That's correct. That's absolutely correct. Yeah, and I'm sorry. We've been going through. I will admit that I spent a lot of time designing and implementing this registry, and so it all makes sense inside my bald head. And we've also the site PIs have talked about this structure over and over again in meetings and shown like overviews of it. And again, I'm glad to clarify that it's an important thing, and certainly it's one of those things. If you do it right the first time, no problem from like that point forward. But if you do it wrong the first time, then it's like a total catastrophe for the rest of
Okay.
the time you're entering data. So I really appreciate you
Yeah.
clarifying that. We'll put that. I think George, that's a good one for us to put in the FAQ to clarify. We tried to make it as clear as possible, but as you can see, it's hard to write that in words on the document.
Yeah, that makes sense. It's like, yeah, I feel like an example is extremely clear and in words it's a little confusing. So that's very
Great.
helpful. Thank
No,
you.
I'm glad we took the opportunity to talk about that today.
Yeah. Those were our like key main questions. Yeah, thank you so much.
No, thank you for bringing them to us because I'm sure that you are not the only person who's going to struggle with that question in the 17 other centers that are going to start doing this over the next few weeks and months. And so it's really helpful to start to clear those up and to have those answers be public so that everyone knows the answer to these important but like sort of fundamental questions about how to enter data.
Yeah, exactly. We were like, we don't want to touch this until we know because it feels like
Perfect.
essential.
Yeah, and as those
Thank
come
you.
up, please let us know either through email or through this kind of session. That's what it's here for.
Thank you so much. Appreciate it.
Rachel and George, anything from I don't think I see anybody else that I haven't called on already and called out. Anything from you guys that was on your mind that has come up when we've been talking to people that you think should be called out either for the recording or for people who are on the call already?
No, I think we'll just keep on updating this FAQ module. And like you said, we'll work on surgical video. But nothing that we haven't gone over already here, as far as I can tell or remember.
For the data champions especially, I know in your data champion committee you guys talk about things like this. George, Ryan, and I are cath doctors. We treat PVS, and so some of the things we imagined we thought would be important to communicate to you are what we did for these, or what Ryan did for these videos and the surgical video that we're hoping to get done. If there are topics that would be really useful or important that you can imagine or have come up in your own sort of data entry practice, letting us know. We're happy to try to support that with either documents or videos or aids. We tried to do our best to imagine what it would be like not to be us, but it is challenging to like think outside of your own lived experience, for sure.
I had a follow-up question. So before the May meeting, I had sent an email like on 5/6 because we had like a second set of questions. And George and I briefly talked about it, about there's answers coming. Do you guys have the answers? Do you want to review them now?
I will admit that I don't remember that set. I'm sorry, Amy. What
That's
are
okay.
they?
I didn't send it out. I thought I did. I didn't. Oh, shoot.
Come on, George.
Hold on. Let me go.
I bet George has it in his drafts, and they're really great answers. Let's look.
Oh, yeah.
No
Let
doubt.
me hold on a second. Let me.
He fell
If
asleep
you want to
while
pull
he
them
was-
up too.
Do you want me to share the questions or just start talking?
Yeah, here. Well, yeah. Why don't you share them while I'm trying to find my, because I'm pretty positive I drafted a response to that. Uh, yeah, May 6th, right?
Yep.
Yeah.
So if a patient
So
is on nighttime oxygen only, how are we recording?
So for the past, again, that same answer that we had for Anna applies here, right? If it's for the current, at a current intervention, you would just say the nasal can't, like the low, based on how much oxygen and how they're getting it, you would use that.
Yeah.
And we wouldn't differentiate between diurnal and nocturnal oxygen, just that they're getting something.
Yeah.
Yeah, it's
Okay.
like a keep it simple person sort of response to that.
Yeah, and I think, and then to your second question there, whether daytime is lower than nighttime, I would go with whatever the higher level of support is.
Agree 100%. Yeah, absolutely.
And then
Go ahead. No,
And the
just
transeptal puncture,
keep
Judah has
going.
asked me. It's just part of doing the cath. We don't call it as another intervention.
right, that's just for the puncture, but if it's a puncture with an intent to make an ASD, like a large one, that's an intervention. But if it's
Yeah,
just
like
a
if you're trying to
puncture,
decompress a kid with pulmonary hypertension or something,
correct.
that's a different, or you stent the septum for some reason or other.
Yeah, but if it's a puncture just to get to the LA in order to do the intervention on the pulmonary veins, no. But then if they balloon the atrial septum with like a 12 millimeter tie shack, then yes.
Yeah. Yeah, Judah, for us, oftentimes you'll see us like use an 8 millimeter balloon. I would just call that to get the sheath across, we're not trying to create a durable atrial hole.
Yeah.
Yep.
But I would also hope that the cath report itself in the intervention section, the intervention, I mean, if it's an intervention to make a durable ASD, that should be in the report as an intervention, not just as.
Totally.
Yeah, that's what I was going to ask. If that, I mean, that would be called out as creating
Yeah. And so for our reports, what it says is like it'll be part of the narrative description of what they did. They'll say like we did a transeptal puncture with a Brocken-Brown needle, and to get the sheath across, we dilated the tract with an 8 millimeter Sterling or something. But it won't say like in the indication or in the procedure that it was creation of an atrial hole. They'll just talk about they'll list what they did because it's sort of our practice to just say what we did. But the intervention will be a pulmonary vein intervention, not a atrial hole creation. Okay.
Yep.
And again, I think that I think this is a good thing for the data champions, just to make sure that they ask that question of how, making sure that they understand in their own record keeping system at their institutions how that's differentiated, right? And each institution is a little different because our reports look a little different. We do have templates for people to use, but they have to match what you guys normally do. We're not going to dictate how you report caths. That's well beyond what we want to do.
The imaging one, I think we hit it hard a couple times during the meeting and such, that it's just kind of like up to each institution how we're kind of a unique situation. So
yeah, you guys have a really interesting situation with essentially a disseminated network of hospitals that isn't just at one site, and more hospitals than most places have to deal with. You have to make a choice on your team about which caths count and which don't. And my advice to you about it is that, like, if you want to count every single time it's from them and you have close to perfect knowledge in a unified medical record keeping system and the resources to like talk to the docs there and want to incorporate that, it's totally fine. But if you can't do that, I would err on the side of using your home institute. And if you want like their information to be part of your quality improvement efforts, all those things, if you're like one unified program, that's great. But if it's we have hospitals we have a relationship with, it's a little different in that they would just send us their PVS patients. They wouldn't, but they take care of them medically, but don't do their interventions at the hospital. It's a little bit further away from us. And so that's a decision I think Shabana and Sean and you guys need to talk about. But it's an important distinction, right? And you can think about it both from a quality improvement and from a research perspective. Missing data, or if you're not going to be able to engage with them to change their practice, that's going to be just frustrating for you guys, I think, in some ways.
Because we do have quite a few patients that come to us just for those cats. So, but they'll be getting their echoes elsewhere, and so that's
Yeah,
where
that happens. That happens to a lot of us. So that
yeah,
definitely
and so
happens
that's
at our
where
center as well.
this one question we had a patient that had over 25 at somewhere else, and
Yeah.
only 7 at our hospital. So we're not counting those 25, correct?
Well, that I would
Because-
not do, right? So if it's in the phase where you're taking care of them, we do want to know if they're getting echoes. And again, the reason why we don't have you entering the ejection fraction, PA size, and TR from each of those is that's kind of a waste of your time. But we do want to know if they're getting 30, 100 echoes, even if it's not at your institution. And you may have limitations, like we have the ability to see when they get CAT scans and lung perfusion scans elsewhere, but we may not have the same depth of information about radiation exposure, for instance. And so you have to enter what you can enter. But it is important if they're getting those services, if they're getting admitted to hospitals, and that. It's one thing if you can't know it, it's just not available to you. But if it is available to you, I wouldn't ignore that.
Okay, so if it's in Care Everywhere, which is in our Epic
That's right.
system,
That's
we
right.
will mark those down. Okay.
That's right. That's right.
Okay.
Thank you for clarifying that, because that's important, and that has come up for us as well. We have a number of patients who live in Baltimore and receive some of their medical care from the Johns Hopkins team, but they get our caths here, surgeries here, and we count the resources that they're utilizing, including short hospitalizations and short and long, at the outside hospital, not just the ones that happen here. Okay.
Yep.
Cool.
The form says short stays are less than 24 hours. The first training video you did at one of the 6 p.m. meetings, discussion, the sirolimus infection would not be recorded as hospitalization, but and one of the previous questions said a sleep study would be recorded. So what is considered a short stay? Not like, what are we looking at?
I don't know what the sirolimus infection one was. I'm sorry. Is it again?
Someone had just brought it up in the training video, asked the question if they were here for an infection, they were just here overnight, would you include
we would
it?
count that as a 1-day hospital admission. That's
Okay.
That's all it is.
Yeah.
It's just a 1-day admission. If they're in the ICU, they're in the ICU. If they're not in the ICU, they're not in the ICU. If they spend a night in the hospital because you did a cath, you count it as a 1-day. Again, the reason is to say, were they away from home for a day? If they were in the hospital, again, this is unlikely, I think, at least in our practice. We have kids who come and get an outpatient cath, a biopsy or something, and leave after 4 hours. I wouldn't count that. That's true, but that's different, right?
Right.
Yeah,
And then,
and I don't think we have to record why they're hospitalized.
Yeah, exactly.
It's just
This is
knowing
the reason why we don't want to record those
Yeah,
things, because
yeah.
that would get onerous and impossible to adjudicate, right? Like,
are recording hospitalizations at outside institutions if it's in the EMR? So
yes,
they went.
I will emphasize that again. Yes, if it's
Yep.
available to you.
Okay.
If it's not, you can't do it.
Yep.
We don't want you to call families and say, like, were you admitted to your local hospital that we can't see, and how
Right.
long? That's too much to ask. But Care Everywhere, for a lot of Epic hospitals, I think really makes that quite good. It can be a little hard to know how long someone's in an ICU in some cases, but if you can, that's really helpful.
Thank you.
No, thanks for asking these questions. These are really important questions. I'm sorry that George has them in his drafts folder, but I'm glad we were able to answer them.
It's interesting. So Amy, I have your email up right here, and in my thing it says I replied on 5/6 at 3:30 p.m., but then I can't find my reply in my sent folder. So yeah.
It's sent somewhere. And when is the FAQ page going to be live so we can?
Yeah, I just went to look. It's not there yet. We are going to put it up onto the page soon, but I couldn't find it right before we started.
It's there.
It's there?
Yeah.
Yeah, under PVS member resources, PVS resources. I'm looking at it. You gonna pull it up, Rachel?
I can pull it up.
Or I got it here.
Okay, thanks.
Oh, I do see it. It's there. Totally.
It's like you freaked me out for a second.
Everyone, see my screen there? And scrolling down, right there.
I'm gonna put the password again in the chat.
There you go.
The member resource section.
Yeah, and again, we'll try to keep this as up to date as we can. I anticipate that in the beginning, there's going to be a lot of stuff added to it. We'll try to highlight the ones that are asked more than once. And then I hope that, as we sort of all get on the same page about this, this will be a resource if you're onboarding somebody, and this will become sort of relatively easy to use. That's our hope, at least. I think those of you who are veterans of doing ductal pulmonary blood flow or other registries, I think it's really, really important to try to listen to and to use the definitions that are applied, and not to have either a site PI or a data champion try to intuit what they think should be the answer to a question based on their own idea about what's important. And so, like, when it's possible, we've been really tried to be clear about what we mean. But if it's not clear, to either use this opportunity or others to find out what the right answer is once, rather than, oftentimes when things are ambiguous, people make assumptions about what they think is the right thing, and that could be right, but it could also be it could equally be wrong. All right. I want to thank everybody for coming to this. I want to thank you guys in advance, and for both what you guys have already done in advance for what you're going to do to try to build these each of your centers' PVS experiences. I really am excited about how much information we're going to have, even in this focused data set, in a way that I think will really help these patients. And I really appreciate everything you guys are doing. If there are questions, I would reiterate what George and Rachel have said already, that PVS email is something that we look at very frequently, and we want to help you. We want this to be successful, and we're trying to set up a system so that you guys can be successful in doing this without too much pain. Okay, you can have 15 minutes of your lives back.
Yeah.
George, good luck on
Everyone,
Saturday
have a
night.
nice
I'll be rooting.
weekend.
I'm not sure I can be rooting for you, but I'll be thinking of you at least.
Well, it's interesting. I fell asleep at the beginning of the third quarter. The last
Oh
game.
my God, really?
I did. I did.
Oh, golly.
Yeah, I
That's
was pretty upset when I woke up and saw like 80 missed text messages and realized what happened.
That was the wildest fourth quarter of a basketball game I think I've ever seen.
Yeah,
Anyway.
I just said that was a special type of horrible play on the Spurs part. So, thank you
Please
for it.
tell me you're not rooting against the Knicks, George.
No, I'm pulling for the Knicks.
Okay.
Oh, George is pure. Yeah.
Okay, because I thought
he's not
he
gonna make
had
ball.
some New Yorker in him, right? He
Yeah.
used to live in New York.
Yeah, I'm a
Okay, I'm just
big
checking.
90
I
Knicks
just want to
guy.
make
I
sure
grew
we're
up
still
with it.
friends after this meeting.
He has a Predators tattoo, but
Yeah. I just won't tell you where. All right.
All right, guys, take care.
Have a good weekend,
Bye.
everybody.
Have a good weekend.
Bye.
Bye.